I've got no conflicts of interest to declare, and these are very much just my thoughts. So, preventing acute lung injury. First two questions, is it important, and is it possible, is it feasible? Well, I think it's bound to be important. Everybody knows that acute lung injury is a condition which causes a significant amount of mortality in intensive care units, and it's extremely expensive to look after these patients. So if you could prevent it, it would be a great thing. And that feeling is endorsed by the great and the good, mostly from the United States, who put it as their second priority at this recent NHLBI workshop. So it is important, and it's a worthy thing to aspire to. Is it possible? Well, I must admit, if I had acknowledgements in this talk, I would acknowledge the Mayo Clinic and my friend and colleague, Oggy Gadget, who works there. This is the Mayo Clinic here. The Mayo Clinic isn't short of money, so they can do a lot of very good research. This is a Rodan, which sits at the front of their hospital. This is somebody who lives in Rochester with issues. And they've done an enormous amount of work to characterize the epidemiology of acute lung injury and ARDS. And I think not only are they a very well-resourced hospital so that they have a lot of people and time to dedicate to this research exercise, but they are also an island surrounded by a vast area. So pretty much everybody in Olmsted County would go to the Mayo Clinic if they get ill. There aren't any other competing hospitals, and this makes their epidemiology quite powerful. This study of theirs over 8 years demonstrated that the patients that were admitted to their hospital as an emergencies, despite an increasing severity of illness, more comorbidities, an increased prevalence of predisposing conditions, the incidence of ARDS decreased over 8 years about 100%. So it halved from 82 to roughly 40. And that was associated with a decrease in mortality and length of stay of these patients who got acute lung injury. And so the question that this raises is, does this change in the epidemiology of ARDS result from practice, which would prove that acute lung injury is in fact preventable? So how do we think of acute lung injury? This is certainly the way that I was taught to think about it. You had a patient that suffered an overwhelming insult that was either delivered through the airways, through a pulmonary injury, or systemically, such as sepsis. So an overwhelming primary insult, maybe some secondary insults. The patient develops ARDS, they get into the ITU, they get full-blown lung injury, they're mechanically ventilated, etc., etc. I think actually we're quite happy with this, and we're used to seeing this sort of thing, young patients getting a devastating dose of swine flu. They get ARDS, we do heroic things like oscillation, prone positioning, and ECMO, and they may or may not get better. I think actually this scenario is at least, if not more common, and I think there is an iceberg situation where a lot of patients who get acute lung injury and ARDS get it quite gradually in hospital over 1 or 2 days. We contribute in a large extent to that, and I think in these cases in particular, the syndrome is preventable at multiple stages. So if you take this alternative patient, let's say it's an old lady with a fractured neck of femur. She's a smoker and a drinker. She has surgery. She gets, let's say, urinary tract infection. Her hemoglobin drops from quite a low level on admission, so she gets transfused. Now, these patients in the UK may be described as being chesty, and they're often supported with a bit of NIV. No real firm diagnosis is made. She may have a little bit of COPD. she has an element of acute on chronic respiratory failure. Almost certainly I would put it to you that this patient has acute lung injury. And if they need NIV, then in the UK they may or may not get admitted to the intensive care unit. Once they are admitted to the intensive care unit, then they are exposed to intensive care junior staff who are inclined to resuscitate patients vigorously with IV fluids. The resuscitation with IV fluids causes the hemoglobin to drop, so they get another hit of transfusion. And then the acute lung injury becomes more evident. The X-ray gets a bit fluffy, they get a bit fluid overloaded. Suddenly they require mechanical ventilation, so they're exposed to ventilator-associated pneumonia, ventilator-associated lung injury, and then they've got ARDS and everyone recognises it. But they've been through multiple stages here which were accessible and amenable to prevention and intervention. And there is some data to support my contention that this is common. At least 50% of ARDS is acquired in intensive care units, and quite a large proportion of patients in AICUs admitted for other causes go on to get ARDS. So this is how I like to think of acute lung injury. Patients come along with precipitating factors, causes or risk factors, and then these precipitating causes interact with patient-centered and iatrogenic modifying factors which determine whether they get acute lung injury or not and what sort of lung injury they get, because all lung injury is not the same. What I like to do is to try and divide up the processes when I'm thinking about acute lung injury into the things which happen acutely, like inflammation, and things which happen concurrently and which determine the patient's outcome, like fibrogenesis and lung repair. So, as I've said, I think it's becoming increasingly clear in intensive care medicine that there is a large iatrogenic component to what we do. A lot of what we do is a necessary evil. And I think in the field of acute lung injury there are 4 outstanding bad guys, 4 horsemen of the apocalypse, if you like, which I'm going to talk about a little bit, predominantly concentrating on fluid overload, transfusion-related lung injury, and my favourite topic, ventilator-associated lung injury, not ventilator-associated pneumonia, which I don't like to talk about, I must admit. So, we all know the data about ventilator-associated lung injury. We all know about the ARDS-ARMOR network study, which demonstrated quite clearly that if you give patients a very high tidal volume compared with a relatively low tidal volume, then you can make a very significant difference in the mortality. Everybody knows, appreciates, understands that, and pretty much everybody would accept that as firm evidence. And if you applied those data to the entire population of the USA, then you would save 10 lives a day. And if you look at it from a financial perspective, and we are encouraged to do that in the current financial climate, we were discussing the situation here, it's exactly the same in the UK. If you paid somebody $10,000 per patient to stand at the end of the bed and say, actually, let's do 6 mils per kilo here, ideal body weight, let's actually do that, then that would be a cost-effective intervention. So this is incredibly powerful. So surely we do it. We're bound to do it because the evidence is there and it's obvious that we should do it and no one would argue with it. So if you compare the tidal volumes applied to patients in a large American teaching hospital type environment before and after the ARDSNet study, there's absolutely no difference in tidal volume per body weight. So we know the evidence is there, it's being demonstrated, and we still don't do it. One of the factors, I think, which contributes to our failure to bridge the translational gap, if you like, and actually do what we know is the right thing, is that we can't be bothered to work out the ideal body weight. And I think that's a problem which is pretty much universal. And we've got better at it only since we've started using our computerized system to tell us on every patient what the ideal body weight is. So I think you really have to ram this information down people's throats. And this is a great study which demonstrated, I know you can't really see the figures there, for which I apologize, but if you compare skinny people with very fat people are at a disadvantage because we systematically underestimate their ideal body weight. So fat people get a much higher relative tidal volume because we don't go the extra yard to measure the predicted or ideal body weight. So that's a little bit about ventilator-associated lung injury. What about what we do about fluids? And again, I think pretty much everybody in the room knows this study. This is the FACT study. Big study done in the United States looking at patients with acute lung injury within 48 hours of diagnosis and protocolizing their fluid management. So dividing patients into restrictive and liberal fluid managements. And they did it well. They made a big difference. Over 7 days, the liberal group were a litre positive a day, and the conservative group were pretty much fluid neutral. And they looked at outcomes, and pretty much everybody knows the outcomes. There was no difference in death, but there was considerable advantage in favour of the dry group in terms of ventilator-free days, lung injury score, ICU-free days, without paying the penalty of a higher instance of other organ failures like renal failure. So that's a great thing. What do we do in real life? Well, this is not quite as powerful as the prospective data that I showed about ventilation, but it shows here, this is the trajectory of the fluid conservative group, this is the dry group, this is the wet group in red here. So these patients did worse, these patients did better. Which group represents the norm, the standard of care? Well, if you compare the fluid balance in the other big ARDS studies which were concurrent, then they all pretty much followed the liberal group. So whilst we know that keeping patients dry is a good thing, we don't actually do it. And in fact, roughly a third of patients who were admitted into this study had a wedge pressure over 18. So I think we're over-liberal in our use of fluids, particularly very early in the resuscitation of septic shock. And I think we're trying to follow, perhaps, the Rivers protocol, using a little bit too much fluid. What about transfusion? Again, pretty uncontroversial that TRALI occurs, probably related primarily to the transfusion of preformed anti-HLA antibodies into patients. Good evidence from the UK SHOT study that multiparous older female donors who'd been exposed to multiple pregnancies would have more of these antibodies and would cause more problems. And this is a lovely case report demonstrating the effects of transfusion on a patient who'd been given a lung transplant here with HLA antibodies which matched the antibodies in the blood that the patient was given, and he got spectacular acute lung injury in his recipient lung. So how do we fare transfusing patients? What's the evidence in ARDS? Well, we know that there's a dose-dependent relationship between red cell utilization and the incidence of ARDS. We know that transfusion of patients with existing acute lung injury increases mortality. And we think probably that leukocyte-depleted blood, which we use, and I think is pretty much universally used now, is probably less injurious. And we know that transfusion of all sorts of blood products causes a relative immunomodulation, which makes a nosocomial infection more likely. But still, despite all the evidence that's been accumulated, still over a third of patients in ITUs are actually transfused, and transfused quite a lot. What's the specific evidence from individual institutions? Well, this again is a retrospective look at transfusion practice over 10 years. And these 10 years span the TRIC study, which demonstrated that not transfusing patients with a hemoglobin over 7, by and large, tended to be a victimless crime. So they looked at 3,500 patients, mostly admitted with trauma, excluding patients with coronary syndromes, hemorrhage and hemoglobinopathy, and looked at patients in 3 groups. Patients with a hemoglobin less than 7 is the top line, 7 to 10 is the middle line, and over 10. And it's clear from this graph that patients over 10 didn't get transfused, so that's a good thing. Patients in probably the most critical group, the 7 to 10, the incidence of transfusion fell from roughly 3% over the course of the 10 years. And patients with a hemoglobin of less than 7, again, a slight fall, with an understandable burst of enthusiasm around the time that the TRIC study was published. And again, the threshold for transfusion is down here, so the patient's hemoglobin at the time that they were transfused was pretty much throughout the study between 8 and 7. So I think this group are doing pretty well. I've audited our practice in our hospital, and we don't do quite as well as that, even in patients with acute lung injury. And I think it's very important to audit your tidal volumes and your transfusion triggers in your own patients periodically as part of good practice to prevent this sort of iatrogenic problem. So, just to recap where we are so far, I think it is important, I think it is possible, some evidence emerging from the Mayo Clinic and elsewhere that it has been achieved to an extent. But what do we need to take this further? Well, we need a way of predicting which patients at risk of getting acute lung injury go all the way to get the full-blown syndrome. If we are going to intervene in these patients, we need to be able to do it in a timely manner. So we need to detect these patients as quickly as possible to institute preventative therapy. We need to have potent interventions to test, and we need to be able to test them in a good way. So we need to have the machinery and the tools to test novel devices and drugs that could possibly prevent ARDS in clinical studies. And there have been a few studies that have come out recently which have informed this debate, and I'll just go through a couple of them. They're pretty much epidemiological studies, which isn't my forte, so you're going to have to give me some leeway when I describe the statistics, which will be a bit of a struggle for me. So this is a study that was done looking at the risk factors for ARDS and acute lung injury. There are three reasons why I've highlighted this study as opposed to the very large number of similar studies which have produced pretty similar results. Important reasons are, one, that this is prospective. So what they did over a 4-month period was to look at patients who were admitted to hospital with one risk factor for ARDS and follow them through. So 800 patients were enrolled, and you can follow the patients through there. The second interesting thing about this study was they didn't restrict their observations to patients who are in intensive care units. They looked at patients on wards and elsewhere, and that gives you a far different feel to the results. And thirdly, this study was done in Madrid in Spain, so that's a good thing. Though I'm not sure actually if Madrid is a good thing in this audience. I'm sure Oriol will tell me afterwards. So what they found out, the take-home messages were that the same risk factors for ARDS were identified as you would expect, predictably. They found that over half the patients with acute lung injury, as opposed to ARDS, so mild acute lung injury, were looked after outside the intensive care unit, which was a surprise. And the third thing which was evident from this study, which was slightly surprising compared with other studies, was that the potency for the risk factors to cause acute lung injury in ARDS was far lower than it was in other studies, and that's because they included patients that didn't get into ITU. So you can see here the main risk factors that you would expect to see: sepsis, pneumonia and shock causing acute lung injury, but with a slightly lesser potency than you would see in other factors. And the last point to make about this study was that it tended to be that the pulmonary risk factors like pneumonia and trauma to the chest caused acute lung injury much more quickly than the indirect causes of lung injury. So by and large, they would have done their business, the red line here, within 2 to 4 days, whereas the blue line, the indirect injury, takes longer to develop as full-blown acute lung injury in ARDS. So that's a useful observational study. What about defining a population from the large group of patients that are at risk? Because you need to define a population who are actually not only at risk, but which are going to go on to get lung injury in order to do studies on assets and devices which may prevent the injury. So you need a prediction score. And this has been largely, this work has been largely been carried out starting off in the Mayo Clinic, where this study was done, and then carried out by, to its completion by a large conglomerate of hospitals in the US, again led by Dr. Gadgets from the Mayo Clinic. So this is the inception of the lung injury prediction score, LIPS. And what they did at the Mayo Clinic was identify retrospectively a cohort of patients with, called the derivation cohort, with acute lung injury. They identified these patients. From the data gained from these patients, they performed logistic regression analysis to identify the predisposing conditions and risk modifiers that the patients suffered and which the patients brought with them to the table. And they gave them a score based on the likelihood of the patients with these risk factors and predisposing conditions going on to get acute lung injury. And then they went on using those data, applying the scores prospectively in a validation cohort, which pretty much showed that the score was equally potent both in the retrospective and the prospective studies at identifying patients or predicting the patients that would get acute lung injury. The two groups were slightly different. The incidence of ARDS in the retrospective cohort, so this is patients who had at least one predisposing risk factor for acute lung injury, was 17%, whereas in the prospective cohort it was roughly 7%. But the potency, the sensitivity, the specificity and the positive predictive value of the tests were all thought to be reasonably good and pretty much the same in the retrospective and the prospective cohort. So thus far, this score, the LIPS score, the lung injury prediction score, had passed muster. So the logical thing to do was to take it into a multi-center study and see how the score performed there. And this they did in 22 participating hospitals, enrolling 5,500 patients. And they did pretty much the same thing. They had a practice cohort to start off with, and then a validation cohort to follow that up. And these two cohorts demonstrated the potency of the lip score. And if you take a lip score of 4 as a threshold, that will give you a sensitivity of 69%, a specificity of 78%, and a positive predictive value for predicting which patients are going to get acute lung injury of 18%. So the score does okay, and it's probably as good as we're going to do. This group, this is the website of the lung injury prevention study group, which are part of the US Critical Illness Injury Trials group. They've published all this data. It's all on their website if you want to go and have a look. And the purpose of doing this is to use the lung injury prevention score to identify a cohort of patients on which preventative therapies can be applied. So if you have a lip score of 4 or above, you would be recruited into a study where you would be given intervention X, and that would and then the study can progress to examine whether X is effective at preventing acute lung injury. I've mentioned already that we need to be able to perform the identification of these patients in a timely manner, and also that the evidence suggests that these patients develop acute lung injury within 1 to 2 to 3 to 4 days. So we need to be relatively quick at identifying these patients if we're going to get the most out of doing clinical trials to prevent the syndrome. And probably the most efficient way of trying to do this is to use automated electronic screening tools. And this study, looking at trauma patients from Philadelphia, demonstrates the effectiveness of this automated tool, which is plugged into the hospital's information systems and will tell you whether the patient is intubated, whether the patient has oxygen criteria which satisfy the criteria for acute lung injury, and we'll have a look at the chest X-ray report, and will, on the basis of those criteria, define the patient of having acute lung injury or not. And what this group did was compare the performance of this automated electronic screening tool with experts, and pretty much the tool and the experts did equally well, and did pretty well with the sensitivity and specificity for identifying patients with ARDS of getting up towards 90%, with an accuracy also of 90%. And the point of this is it's not interesting, but it does demonstrate that you can have an automated system that will flag up patients who are about to get ARDS pretty quickly. So this is doable in a large, well-resourced institution. Can these devices be used for anything else? Can they be used to improve therapy? Well, this again, back to the Mayo Clinic, is the so-called sniffer, which detects whether you junior doctors at the back are doing the right thing with your patients. So this will identify patients who have satisfied criteria for acute lung injury, will determine whether the X-ray is compatible with pulmonary edema, and then it will look at how you're ventilating the patient. And if you're ventilating the patient with peak pressures which it thinks are too high, or tidal volumes that are too high, then it will bleep you and tell you to go and have a look at the patient and have a look at the ventilator and see what the problem is. How do you fancy that? Well, in this study, the junior doctors said that they thought this was a good idea, but they would, wouldn't they? Did it work? Well, it did work. It was very effective. It halved the amount of time that the patients were exposed to injurious ventilation. So these automated systems can be used to reinforce the messages which are out there but not getting through to the floor. How else can prediction be improved? Well, I think this is pretty much a tale of failure so far. We have tried very hard to characterize robust biomarkers of acute lung injury. These are examples of mostly inflammatory medias or markers of epithelial or endothelial damage, which have been measured from samples from huge cohorts of patients undergoing ARDSNet studies. And you can demonstrate that the following biomarkers are significantly raised in patients who have acute lung injury. You can demonstrate that patients who do slightly worse sometimes have higher levels of biomarkers. Have they been clinically useful? No, they haven't thus far. Pretty much the only biomarker which is measured from the blood, which I think is useful in clinical practice, is procalcitonin. And I don't think any of these are going to break through into the clinic. However, if they're used in a research framework to try and improve the performance of a clinical prediction score, then if you compare the predictive capacity of the biomarkers alone, the red line, with the clinical scores alone using Apache 3, then combining biomarkers, a panel of biomarkers with a clinical score, can increase your sensitivity and specificity for identifying patients that are going on, that will go on to get acute lung injury. So this is possibly something which could be developed in the future. This is my favorite biomarker study. Apologize if you've seen it before, but I think it's extremely elegant and clever. And there's a study that was done on only 30 patients. So this group in Milan, I think, took patients with ARDS, ventilated them according to ARDS criteria, did CT scans, and divided the patients into two groups. And the group on the left, 10 out of 30, had CT scan evidence of hyperinflation on their CT scans, despite the fact they were being ventilated according to the gold standard, whereas the majority of patients were free from this evidence of hyperinflation. They looked at the data from the ventilators and observed that the patients with a plateau pressure between 24 and 27 were in this group, and the patients between 27 and 30 were all in this group. So you can use the patient's plateau pressure to identify patients who are being ventilated at the gold standard and predict which of these patients are suffering ongoing lung injury, which was, in this study, it's almost too good to be true, associated with raised levels of inflammatory markers. So they used this information to do an interventional study, again with relatively few patients, 30 patients, and in this case they divided the patients according to the biomarker which they'd identified. So patients with a plateau pressure between 25 and 28 had conventional treatment with lung lavage and CT scans to characterize them, whereas patients in the high plateau pressure group went through the same diagnostic algorithm, but they had ECOR, extracorporeal CO2 removal, which allowed them to dramatically reduce the tidal volume that was applied to these patients. And then they underwent the same investigations. The main outcome measure was the measurement of inflammatory mediators. In the patients who you would predict not to have damaging mechanical ventilation at baseline, the inflammatory markers were lower than the patients with the high plateau pressures, and they stayed pretty much the same over the course of the 72 hours of the study. However, the patients with the higher plateau pressures had initially much higher levels of cytokines in their circulations, which dropped dramatically after the institution of ECOR and lower tidal volume ventilation. And the clever thing about this is not demonstrating all this, which has been done before, but it's this, that you can divide these patients into two groups just based on their plateau pressure. So what's coming in the future which is going to make a big difference? Well, I think this is going to dramatically affect how we look after patients with early, mild, acute lung injury and other respiratory problems. These are devices which are emerging onto the market which will carry out extracorporeal CO2 removal without the drama and the expense of associated with the current Novalung, the arteriovenous device. These are all veno-venous devices which are at various different stages of development. How do they compare? Both with the existing Novalung and with veno-venous ECMO. The vascular access can be achieved with a single cannula in the internal jugular, which is of reasonable size compared with the two cannulae of the current Novalung device. The blood flow rate can be relatively low because it's veno-venous rather than arteriovenous. The venous blood obviously contains a lot more carbon dioxide, so it's easier to get the carbon dioxide out, so you don't need such a high flow rate. You can pretty much only achieve carbon dioxide removal with a caveat that the new Novalung Active can be upgraded to a higher flow system if you put in a larger cannula. The big thing, though, I think, which is going to make a big difference is that patients on these systems, these veno-venous, new veno-venous ECOR systems, can be mobilized. You can avoid intubation and mechanical ventilation in these patients, and therefore you can prevent all the issues associated with ventilation of patients with injured lungs, immobilization, etc., etc. They don't, as far as we know so far, have the same bleeding problems associated with ECMO, and they can be upgraded to ECMO, though they are still pretty expensive. So I think this could possibly make a big difference to the way we look after these patients. So finally, in summary, I've introduced some strategies which I think will enable us to examine new ways and to carry out in a more rigorous way to bridge the gap between what we already know from translational medicine into practice, so that we can achieve both primary and secondary prevention of acute lung injury. I've talked a little bit about scoring systems and biomarkers so that we can predict which patients to concentrate on. And the interventions, the most important interventions that we can carry out at the moment are educating colleagues, making sure that we're all trying to do the same thing, and regularly auditing our practice so that we know that we're doing the right thing. I think we're going to be, whether you like it or not, subjected to automatic surveillance in the near future, so that Big Brother can tell what we're doing and make sure that we're doing the right thing. I think devices are already there that will make a big difference to these patients with acute respiratory failure, and who knows, maybe one day we'll have drugs which can prevent acute lung injury. So thank you very much for your attention. For me, Barcelona, my first consciousness of Barcelona was at the Barcelona Olympics. These are the Searle brothers who won one of the best races I've ever seen in any sport, so have a look at that. Then my next awareness of Barcelona, I'm afraid, was us beating you in the early 90s in the Cup Winners' Cup final, and then we sold you Mark Hughes, who was useless. And then more good stuff. We won the European Cup final in the Camp Nou after playing appallingly for 88 minutes. But things recently haven't been so good, and I think Lionel Messi is quite like acute lung injury. You know he's there, you know he's coming, but unfortunately at the moment we're not able to stop him. So thank you for inviting me, and thank you very much for your attention.
Thank you very much. Definitely I invite you to stay with us tomorrow for the Real Madrid Barcelona match. It's been a pleasure to enjoy this very nice presentation. My first question is, 12, 13, 14 years ago I attended APS, and it was presented the protective ventilation strategy. I was very impressed and arrived with the abstract and distributed to my staff and myself. But really, in the past 13, 14 years, there are any real advance in prevention and management of acute lung injury?
No, they haven't. And there are multiple reasons for that, and I think there are a lot of things that you can say about that. I think acute lung injury is so heterogeneous that it's incredibly difficult to study. It's extremely difficult to characterize patients well enough to do studies which stand any chance of success. These days, now that protective ventilation is almost universal, you need well over 1,000 patients in a study to get a positive result. And a lot of the studies which have been done, for example, trying to determine what's the right level of PEEP, to my mind had absolutely no chance of succeeding because they were dramatically underpowered, and because it's almost impossible to proscribe the correct level of PEEP because it's different for every patient. So I think there are multiple reasons why we haven't made progress beyond protective ventilation. But conversely, we know about protective ventilation